Bismillah ar-Rahman ar-Rahim. The diagnosis of mesothelioma. Definition. Mesothelioma is a malignant tumor of mesothelial surfaces, most commonly the pleura, usually resulting from asbestos exposure. Causes of mesothelioma. Asbestos is the major single cause, and there is a history of occupational asbestos exposure in up to 90% of cases. All types of asbestos can cause mesothelioma. Amphibole is the most potent, but also evidence for cryosteel. Many mean latent The mean latent interval between the first exposure and the death is around 40 years. Cases are rare with latency below 15 years. Not those related, unlike asbestosis or bronchogenic cancers, and no evidence for a threshold asbestos dose below which there is no risk, although the risk at low exposure levels is small. No significant association with smoking, and the mechanism through which asbestosis or asbestos fibers result in mesothelioma is unclear. Possibilities include direct irritation of the parietal pleura, disruption of mitosis, generation of the toxic O2 radicals, and the stimulation of the mitogene activated kinases leading to proto-oncogene activation. Other causes of mesothelioma include non-asbestos fibers, erionite, which is found in rock in Cappadocia, Turkey. Mesothelioma accounts for up to a quarter of all adult deaths in local villages. Evidence for Simian virus 40 contaminated poliovirus in the 1950s and 1960s is limited. Rare cases of mesothelioma caused by ionizing radiation or chest injury are described. Spontaneous mesothelioma in children also documented. Clinical features and clinical features of pleural mesothelioma: chest pain, typically dull ache, boring, diffuse, occasionally pleuritic, breathlessness. A small proportion of asymptomatic profuse sweating may occur. Consider in any patient with a pleural effusion or pleural thickening, particularly if a chest pain is present. Rarely may present with persistent chest pain and a normal chest x-ray. Weight loss and fatigue uncommon at presentation, below 30% of cases. Clubbing is very rare, below 1%. Regarding weight loss, may be prominent if the disease progresses. Clubbing, as we said, is very rare, below 1%. Chest wall invasion may be seen especially at thoracentesis sites. Bilateral pleural involvement is unusual presentation, and paraneoplastic syndromes are described, which is disseminated intravascular coagulation, as for example. Again, paraneoplastic syndromes are described, for example, disseminated intravascular coagulation. What is the differential diagnosis, or what are differential diagnoses of mesothelioma? The differential diagnoses include benign asbestos, pleural effusion, diffuse pleural thickening, adenocarcinoma involving the pleura. Investigations. Pleural fluid. Aspiration typically reveals oxidative, straw-colored or blood effusion, and cytological analysis may provide the diagnosis. Sensitivity ranges 32 to 84% and is often usual in excluding other pathology, as for example adenocarcinoma, poor at diagnosing sarcomatoid mesothelioma, pleural fluid glucose and pH may be low in extensive tumors. Mesothelioma may track through the chest wall along thoracentesis. Avoid repeated pleural aspiration if the diagnosis is suspected. Imaging. Chest X-ray and CT features include moderate to large unilateral pleural effusion, usually with pleural nodularity and enhancement following pleural contrast and involvement of mediastinal pleura. Localized pleural mass or thickening without free fluid, uniform encasement of lung resulting in small pneumothorax, local invasion of chest wall, ribs, heart, mediastinum, hilar nodes, and diaphragm, transdiaphragmatic spread and invasion of contralateral pleura, associated pleural plaques, or interstitial fibrosis in a minority of cases. The role of magnetic resonance imaging (MRI) is unclear. It may provide additional information in some cases, e.g., chest wall invasion, although is rarely required. PET or CT may have a role in distinguishing benign and malignant pleural disease, although TB, pleuritic talc, and chronic pleural inflammation cause 18 fluorodeoxyglucose (FDG) avidity, as well as identifying lymph node spread or staging, and can help to select sites for image guided biopsy. The biopsy. Diagnosis usually requires histological confirmation, except when the patient is too unwell or too frail for biopsy. Ultrasound or CT guided cutting needle biopsy and thoracoscopic biopsy of pleural masses have a high diagnostic yield and should be used in preference to blind Abraham's biopsy techniques. Early use of thoracoscopy may both provide a diagnosis and enable treatment of large effusions with talc pleurodesis, thereby avoiding repeated non-diagnostic procedures with attendant problems of needle track spread. Histological subtypes of mesothelioma. Epithelioid type, in which 50% of cases may be confused with adenocarcinoma and it has better prognosis. Sarcomatoid type or fibrous include lymphohisto- lymphohistiocytoid and desmoplastic patterns, worse prognosis. Mixed biphasic contains both subtypes. Immunohistochemistry is key to making the diagnosis. The British Thoracic Society guidelines suggest use of two positive mesothelial strains, e.g., caliritenine, cytokeratin 5 over 6, Wilms tumor 1, and podoplanine D24, D240, and two negative adenocarcinoma stains, e.g., thyroid transcription factor TTF1, carcinoembryonic antigen CEA, and beer EP4. Difficulty with sarcomatoid mesothelioma, which frequently does not display mesothelial markers. Electron microscopy of histological specimen may also help to distinguish mesothelioma from adenocarcinoma. The eighth edition of TNM staging system for mesothelioma, extent of one tumor, one zero tumor, T, Tx tumor cannot be assessed, T0 no evidence of primary tumor, and T2 T1 tumor and limited to ipsilateral pleura, T2 tumor involving the ipsilateral pleura with either the fram muscle involvement, A, which takes A, B, extension into the lung, T3 locally advanced resectable tumor involving ipsilateral pleura with endothoracic A. Endothoracic fascia involvement. B. Mediastinal fat involvement. C. Resectable chest wall tumor. D. Involvement of outer part pericardium. And T4. Locally advanced unresectable tumor involving ipsilateral pleura with A. Diffuse or multifocal chest wall disease. B. Extension to peritoneum, C. Extension to contralateral pleura, D. Extension to mediastinal organs, E. Extension into spine, F. Extension through pericardium, plus or minus pericardial effusion, plus or minus myocardial tumor. Regional lymph node, NX cannot be assessed, N0 no regional lymph node metastasis, N1 ipsilateral bronchopulmonary hilar or mediastinal nodes, N2 contralateral mediastinal ipsilateral or contralateral supraclavicular nodes, and the distance MX cannot be assessed, M0 no distant metastasis, M1 distant metastasis. That's all about mesothelioma, and thank you.